Welcome to APCIS Online 2020. I'm Sung-ho Kim from Sejong Hospital. I will moderate this webinar with Dr. Chang Ali,
Yeah, nice.
our great surgeon. First of all, I would like to thanks to all the audience, panelists, and speakers for joining our webinar actively. Actually, COVID-19 has changed everything in our life. So our webinar, our APCIS meeting also changed our format to web-based seminar. You may remember the previous webinar performed on July. The topic was correct TGA. At that time, we had many mistakes. Even though we made many mistakes, I think at that time we had a hot discussion about the correct TGA, and I do believe it was a successful one as a first webinar from us. So at this time, we have prepared meticulously, so I hope you can enjoy our webinar very much. I think one of the advantages of the web-based seminar is the audience can enjoy the wine or snacks while joining this seminar. Okay, so our webinar has two days program. First day, today, we will have two sessions. First session is interventional one. The topic will be percutaneous pulmonary valve implantation. And second session is a surgical one, the aortic valve surgery in pre-adolescents. Today, we have many distinguished speakers and panelists. I would like to introduce one by one. So please show their faces. And when I call on your name, please raise your hand. And the first speaker, Beom Kim. Raise your hand.
Good evening.
Okay. And the second, Worakan.
Hi. Hello from Thailand.
Okay, Worakan. And Choi. He's now, okay, I can see you well. And yeah, next our panelist, Bharat Dalvi. Okay. And Sung-Hae Kim from Shizuoka, Japan. Sung-Hae Kim. 패널들 얼굴을 한꺼번에 다 띄우라고 그러니까.
It's Sung-Hae.
Okay, hi, how are you? And Dr. Tin from Hanoi, Vietnam. Not Hanoi. Dr. Tin. I contacted him just before, but okay, later. And Soik Jang Soik.
Thank you.
Okay, that's good. Okay, tomorrow, the second day, we will start at 2 p.m. to 5 p.m. We will have a challenging cases competition. We have 9 cases, 6 cases interventional one, 3 cases surgical one. So we will have a very hot time tomorrow. And the following session is a video demonstration session. The topic is conduction system moderated by Dr. Jung-Wook Seo. So please join tomorrow too. Okay. Yeah, that's my introduction, and I would like to start my first session. I would like to call on our first speaker, Dr. Beom Kim from Seoul National University Hospital, Korea. His topic is about the PULSTA valve, tips and completed cases. Dr. Beom Kim, please.
Now, can you see my slide?
Yes.
Okay, thank you. I'm so pleased to be invited again to introduce PULSTA. So this figure shows the increasing cases of PULSTA implantation nowadays. So since the first feasibility study in our center 4 years ago, we finished the Korean FDA approval study last year May in 5 centers for 15 patients. And finally, we got the Korean FDA approval last year September. Since then, for last 1 year, 94 patients already successfully implanted PULSTA in 6 countries in 15 centers. So from this experience, it's my great honor to introduce the tips of PULSTA and the challenging cases. Many of you already know that the PULSTA frame, the standard strut was made using a knitted woven texture natural wire backbone with self-expanding nature. And the treated porcine pericardium was covered 25 millimeter height, and the treated porcine pericardium was stitched as a tri-reflex valve between these two radiopath markers. And this profile is approved from Korean FDA. Outer diameter range from 18 to 32 millimeter, and total height is 33 or 38 millimeter usually, and 4 millimeter larger flaring in both ends for the stable positioning. And as like other self-expandable valve, the partial landing zone is main pulmonary artery from the pulmonary annulus to distal bifurcation site. And as you know, the native alveoli has a very diverse shape. So according to each shape, we should design where we input the PULSTA valve. So this type 1 pyramidal shape is most challenging cases. So be careful to implant and just implant in the deep bifurcation site like this. And this type 2 straight shape is straightforward. So just implant in the middle of the main pulmonary artery. And you can see the valve function like this. And type 3 reverse pyramidal shape, very challenging. Be careful and very high risk of valve instability. So design PULSTA implantation if landing zone is enough. So and some patients may need pre-stenting if there is a stenosis like this. And type 4 convex shape, implant into the pocket or at the just distal bifurcation site according to main ear length, like this patient. And type 5 concave shape, implant into the narrowest site, like this. And may need some patient pre-stenting if there is a significant stenosis. And balloon size of main PA is give much information to decide the procedure. Using 34 millimeter sizing balloon, I usually see a main pulmonary artery dilatability and do rough coronary artery compression test. But sometimes be careful not to do oversizing. Like sometimes this balloon can be dilated up to 40 millimeter. And balloon interrogation test using Tyjab balloon, usually I do some patient to see feasibility for borderline size main PA. And when we need the precise coronary compression test, I usually do this balloon interrogation test. So this from many multiple imaging modality using echo, CT, MRI, angio, we decide valve sizing. Usually 1 or 2 millimeter larger valve than over main PA diameter, or 3 or 4 millimeter larger than narrowest side diameter. But anyway, you can decide oversizing if you worry about valve migration. The wire selection is also very important for more smooth and safer procedures. If you decide the wire solution left pulmonary artery give us better trackability in the main pay landing zone, but sometimes some risk for foot block detachment failure at this area. If you select right pulmonary artery wire selection, better for foot block detachment, and you can see very little valve alignment change after full deployment, but sometimes give less trackability than left pulmonary wire selection into the main PA landing zone. So by rolling the knob clockwise, we can deploy partially the distal part. And during this maneuver, keep the tension during deployment. So keeping this position, if you lose this tension, the valve can be moved down because of the wire tension. And when you finish rolling the knob, you see the distal flaring. If the distal flaring is not enough, pull the slide very slowly, taking slow deployment. In that case, sometimes the fast pulling the lever may risk valve migration. Very careful in this procedure. So from now on, I like to introduce several challenging cases until now. This patient, 32-year-old male, near functional class 3 with severe kyphoscoliosis like this. The surgical PVR was refused at our hospital, so visit our clinic. From the echo, you can see very large right ventricle, and from this patient, we found very short main pay length, about 20 millimeter in the echocardiography. And from angiography, we also can see the short main pay landing zone, about 20 millimeter from annulus to distal piping site. So after careful measurement, we decided to implant first of 28 millimeter diameter and total length 30 millimeter. So after careful implanting the valve, you can see well seated the first valve here. And from the echo, there is no PS, PR from the Doppler echocardiography also. Just that day, patient feel very comfortable, so patient feel very happy about that. This patient, a patient with LPA stent, from the CT and echo, you can see the proximal LPA stent protruded into the main pulmonary artery. So careful measuring the angiography, we decided also 20 millimeter diameter and 33 millimeter length first valve safely, implanted safely. And this procedure was also done in Taiwan. The 30-year-old patient, LPA stent was done in the lab using CP stent. And also from this view, you can see the LPA stent proximal part protruded the main pulmonary artery. And the effective landing zone of main phase seems to be short. So carefully wire selection to right pulmonary artery. We also selected 28 millimeter diameter, 33 millimeter length, total length, first valve. And you can see well seated in the annulus level, and there is no PR after valve implantation. This patient was done at the Sejong General Hospital. Thank you for Dr. Song Kim and Jae Kyung. This patient, 60-year-old man with RV dysfunction, neck function 3, and also because high risk surgical PPVI refers to interventional valve implantation. So they implanted the first valve in both branch pulmonary artery. From the CT, the main pulmonary artery looked very big. So annulus level 29, 30, 31, and sinus level 48 and 52. So impossible to implant first valve here. So they designed the implant, the branch pulmonary artery. So carefully measuring the branch diameter, implanted the PULSTA valve 32 millimeter in right pulmonary artery like this, and no PR, and also left pulmonary artery like this. So after implantation, main pulmonary artery angiography shows like this, very big branch pulmonary artery. We can they treat it like this, and the 3 months follow-up showed still enlarged right ventricle, but we expect this patient right ventricle could be remodeled for better function. The next case is done in Argentina with Dr. Johannes Roja. This patient also very old male, 65-year-old male with moderate case and severe PR. He had functional class 3 also. High risk of surgical treatment because hypertension, Beom, dyslipidemia, and overweight. RV function was very low. And you can see the main page showed the calcified pulmonary artery aneurysm level and enlarged both branch pulmonary artery and RVOT. When they did sizing balloon, measured around 20 millimeter. So we implanted the CP covered stent, hinging 45 millimeter with the PIB 26 millimeter balloon catheter, like this. Careful implant CP stent, covered CP stent. Over there, we implanted the first valve, the 28 millimeter, 38 millimeter successfully. And after that, you can see there's no pulmonary regurgitation. Also, the pulmonary stenosis regressed very well. So until now, so we successfully implanted 119 patients. And for the last 1 year, we have to current FDA approval. We implanted 94 patients by yesterday, and among them, there was compassionate use in Taiwan 11 patients, Argentina 4 patients, and Vietnam 1 patient. And the approval study was done for the 20 patients by last February, and then COVID-19 prohibited our continuing procedures. But we started the valve implantation again. So now, last week, 2 technicians from Promphan company went to Europe. So maybe for next 2 weeks, we expect 7 or 10 patients. Valve implantation will be done in Italy, Spain, and Turkey. So from this slide, I'd like to say this valve is give longer durability because we have done specific tissue treatment for last 10 years. And this valve is not working that long, so very user-friendly. It's easy valve loading and good dragability in the target main PA, and can be implanted in the previous patient with branch-based stenosis, main PA, and even in the triangular-shaped main PA, like this the patient today I introduced. And because of knitted nitrile wire stent nature, low risk of stent fracture in the dynamic valvular area. And until now, we finished the 8 patients per year follow-up. There was no stent fracture until now. And we are using a low-profile delivery catheter, 80 French for up to 28 millimeter, and 20 French for 30 millimeter valve. And because of rather short height of the total valve height, so I think this is ideal shape to review PPVI after next time intervention. Thank you for your kind attention.
Thanks, Dr. Kim, for your excellent presentation with very interesting cases. We will have a discussion time at the end of all the speakers talk. The next, I would like to introduce next speaker, Dr. Worakan from Thailand. He will talk about the venous P-valve, also tips and complete cases in percutaneous pulmonary valve implantation with the venous P-valve. Worakan, please.
Yes, Songho, thank you very much indeed. Can you hear me clearly, right?
Yep.
Okay, yes, so first of all, that's very fascinating, Beom, showing the case that bilateral PA implantation of the PULSTA, that was very fascinating. And then also I would like to thank Songho and all the APCIS team to hosting this meeting. I think this is very important thing to do in the COVID time to get everyone together. So this is my disclosure. So as mentioned previously by Beom, that the venous P valve and similar to the PULSTA and the harmony for the Medtronic, that this is the self-expandable valve which made from porcine pericardium. So the venous P is here, and as you can see that the maximum diameter for the venous valve is 36 millimeter, which is the largest diameter at the moment available for the native RVOT. Of course, this is a large profile because it's intended to use for the large native RVOT. And again, just to emphasize that it's made for the largest valve diameter so far. So for those who not know the venous P, it's made from the laser cut nitinol wide frame. Not connect, but there's a porcine pericardial tissue sewing around this part. So this particular area is intended to use at the bifurcation in order to avoid gelling of the pulmonary artery branches here. At this position, supposed to stay at the right ventricular outflow tract in order to seal the outflow to make sure there is no paravalvular leak down below, or there is no paravalve leak up against the flow here. And the diameter, as mentioned previously, the smallest one is 22 and the largest one is 36. And the diameter at the flare proximally and distally is about 10 millimeter larger than this diameter, and also 10 millimeter add up here and add up there. So in total, if the straight part here is about 30 millimeter, plus 10 here, plus 10 there, going to be 50 millimeter from below to above. And as you can see here, this is the ear of the venous P valve, which intended to connect to the delivery system to put the valve into the right position and then deploy it. So inclusion criteria, I think it's quite similar to other valves. So the body weight should be at least 30 kilo, and you should have the evidence of the valve regurgitation, especially the pulmonary valve, more than 2 to 3 plus by the echo, transesophageal, transthoracic. And also you need to have the symptomatic symptoms, or the patient should meet the CMR criteria for intervention. Something like ejection fraction on the right side is decreasing, or the PR fraction is more than 30%, or the right ventricular end diastolic volume index is increasing. This number, I think, is still moving, and most of the time that tends to come even lower than this. But just to make sure that, again, any kind of valve, when you implanted it, this kind of clock is ticking. So the longevity of valve, you never know. Mostly should be longer than 5 years. But again, if it's not really important to implant, we need to make sure that we have to wait until it's the right time to do it. For the venous P valve, as a routine, we urge the operator to perform cardiac catheterization just to evaluate RVOT and to make sure that you have the proper balloon interrogation before you decide to implant this valve. because this kind of custom-made length and also diameter to accommodate with the anatomy of the patient's RVOT and MPA. So the tips. In general, you can appreciate the main pulmonary artery and right ventricular outflow tract by 3 projections. The first one, which is quite commonly used, is RAO cranial and also LAO cranial. And as you can see here with this, you can see the elongation of the MPA very nicely, but you cannot see the bifurcation properly. But on the LAO cranial view, you can see the bifurcation very nicely, but the MPA is foreshortening. And the lateral view is very clear, seeing that where is the right pulmonary artery and where's the LPA and where should be the landing zone here. Most of the time, the length here is quite correct, quite proper to make decision. But again, sometimes it may foreshortening. But as usual, if you want to see the bifurcation, you should go for the LAO cranial. If you want to see the length of the MPA, you should go for the RAO and LAO also. You need to be using this to confirm the diameter and the length. And it's a like kind of complex measurement, but just to make sure that you measure the waist properly, you measure the most dilated part properly, and also you measure the length properly. And after that, as Beom mentioned, this is quite important, even if it's not really crucial, because most of the cases with the native RVOT, the coronary artery compression is not a big issue, but I still doing it in all the cases, even if it's not the conduit case. So as you can see that for the venous P, you can use the ASC sizing balloon because that radial force of the venous P is quite suitable to interrogate with the sizing balloon, which is quite compliant balloon. And one thing you need to see also, not just the waist, but also the most dilated part here, part of the coronary artery course. And last but not least, you see that the interaction between the aortic root and the balloon here, you see is moving like this. So what does it mean? It means that some valve, when you implant it in this area, it may compress the aorta and may cause the aortic regurgitation. This is not the case for the self-expandable valve. And also, you need to make sure that the balloon is fully inflated by checking the RV angio while balloon is inflating. And you see that there is almost no contrast media going to the pulmonary artery. So this means that you get the good waist here, which is the most dilated diameter, most dilated, most inflated diameter. That will be the diameter that you're going to use for the measurements. Again, make sure that you got the proper measurements, especially for the waist and the most dilated part. And after that, you need to decide the landing zone. So how can you decide? In general, you need to find the waist. In this particular case, it looked like a tubular, but actually there's a double constriction here. One is here and one is there. And the bifurcation is just a little bit larger than the middle part and also the pulmonary valve annulus. So we're going to decide this as a landing zone for the proximal valve, the venous P valve. And after that, you need to imagine that the flare going to stay here, the proximal flare, and then the distal flare likely to stay there. And with that kind of imagination, you can eventually understand that what should be the proper length of the valve that you're going to use. So in this particular morphology, 20 to 21 millimeter valve length should be at least okay for this anatomy. And after that, you need to decide the valve diameter. And as you can see that the measurement here, the waist is about 20 to 23 millimeter, while the most dilated part is about 30 to 28 to 30 millimeter. So in general, you should not go beyond this diameter in terms of the diameter of the valve. And you should not go beyond this number more than 6 millimeter in terms of the valve selection. In this particular case, that will be 26 millimeter valve diameter with the 25 millimeter length of the straight part. So after we know exactly what size and what length of the valve we're going to use, and then we're going to implant the valve. So in general, as similar to other valves, we prefer to go for the left pulmonary artery as most distal part as possible, just to make sure that the wire is, have a strength enough to load the delivery system. And after that, you, with the frequent check angio, make sure that you see that here's the waist that you want to land the proximal valve here, which has a marker here. So the intended position of this marker should stay around here in the lateral view. And in this RAO view, this marker should stay around there. And then you just slowly open the valve. And again, no need to rush. You just coming down slowly and open it. This valve it takes some time to flare. So with a gentle opening and also just careful check the position, and then you know exactly that now you are very close to the landing zone here. And after that, you just open more and more and more of the valve. And while the valve is almost completely open, as you can appreciate that the flow is very limited to the pulmonary circulation. So it means that the patient may develop hypotension. But after that, if you make sure that the valve position is in the right one, and then you just completely deploy the valve. And again, just to emphasize that the marker here is nicely matched with the position that you really want to put the valve in. And also the flare here is completely stay at the right position, which avoid the obstruction of the flow to the right and left pulmonary artery. So this is a quite perfect position for the valve, this valve to land. Again, the valve function looks okay and no paravalvular leak. So how about complicated case? Just to share with you this particular case, which has been treated about almost 10 years after, 10 years before transannular patch repair and LPA PULSTA. But for some reason, the patient still had the problem with the LPA stenosis, so we need to put the stent in order to reduce the to avoid the obstruction of the flow to the left pulmonary artery. And as you can appreciate by the 3D printed model here, that the RVOT looks like that. It's not really round, but it's kind of ellipsoidal shape. But the left pulmonary artery stent is actually protruding into the lumen here when you look from the right pulmonary artery. And RPA is quite dilated. So again, it's quite challenging in terms of the deploying the valve into the right position. But again, we decide to use the venous P that time to put into this patient. And this is RAO projection, this is lateral projection, and this is balloon interrogation of the patient. So, so we decide to put the valve from the femoral vein. But unfortunately, as you can see here, because of the angulation here is quite acute from the RV and then to the MPA is like that. In general, if the angle here is like that, that would be quite easy. But with this kind of angulation, we cannot, unfortunately, advance the delivery system from down, from femoral vein to the pulmonary artery. So eventually, we decide to go from the right internal jugular vein. And as you can see here, that because the valve itself is quite a lot of the length, and also the system here is quite long one. So it takes a little effort to put this delivery system into the position at the main pulmonary artery. But eventually, it went through. And after that, the rest of the procedure was quite straightforward. So we opened the flare here, and as you can see, the flare is quite very nice, accommodating with the position of the bifurcation without gelling of the LPA stent. And then we implant the valve successfully. So this is the final position and the final angio. just to show that the valve is sitting very nicely. And just recently, we know that when we deal with the very difficult anatomy and very sharp angulation between RVOT and PA, using the dry seal sheath in order to advance the delivery system into the right position before we implant the valve is quite useful and very easy. So with this kind of dry seal sheet, 65 centimeter, it's much easier to deploy the valve successfully, as you can see here. And also we did have a hard time, thanks Robin Chen and his team in Queen Mary Hospital in Hong Kong. This is quite very one of the kind case that the patient got the esophageal atresia and the patient got the gastric pull through here. So that's the reason why the surgeon is very difficult to do the median stenotomy. So the patient post top repair, but for some reason, patient got a problem with the severe pulmonary regurgitation. And as you can see, the distal MPA measurement is about 38 millimeter. So with the surgical team discussion, so we decide to applicate this area of the MPA by left thoracotomy to reduce the size down to 28 millimeter, and then we can successfully implant the valve, the venous P valve, in that position. So again, in terms of the procedure, I think there is a modality of the valve that you can manipulate. So how about long-term result? I just take a quick look of this, just to show you that now some patient is reaching the 6-year follow-up, and most of them, severity of the PR is, mild. There's one patient in moderate degree here. And the CMR follow-up, RV-EDV index mostly remain the same. I mean, in the level below 150. I'll show you about this patient very soon. And the CMR PRF is very low, less than 20%. And this patient is actually the one that that's his very first case of our experience using the venous P valve. So the valve is accidentally pulled it back into the RVOT because one of the ear is not completely detached with the delivery system. So that time, the valve is deployed a bit lower lying. And as you can see here, there's a tricuspid regurgitation. So that's causing degree of the tricuspid regurgitation causing the RV-EDVI not completely down to normal. This is immediate angio showing the TR. So this patient, we did follow up, and the 1 week post, the patient has a TR here, which is quite big volume. And then 3-year post, still having a heart that doesn't come down. And 6-year post, heart size still getting quite big. So with the follow-up of the echo, TR doesn't come down. And at 6 years follow-up, the RV-EDV index remains high, and is actually quite increasing. So we decide to ask the surgeon to take this valve out. And just to show that TR is torrential, but the pulmonary valve implanted, I mean venous P, you can see it, the valve is functioning very nicely, sitting very nicely without problem by the echo. And this is how the surgeon see the valve when they try to explant it. This is a tricuspid valve, and this is the right ventricle. And here is where the valve is sitting at the RVOT. So the surgeon took probably about almost 10 minutes to remove the 6-year implanted valve out of this kind of area of RVOT MPA. And this is how it looked like. The valve function is remain intact in vitro and in vivo. And you can see the valve shape, from above, from below looks okay. There's a good endothelialization, but it's not a big issue to remove this valve out after 6-year implantation. And this is a pathological section of this valve. And this is a valve leaflet in histology, which remains very intact in terms of the function. And this is how the human tissue combined with the porcine tissue for the venous P valve. So in conclusion, ladies and gentlemen, this venous P valve, I think is suitable for the medium and large native RVOT, and it can be used large up to 33 millimeter, with MPA length should be at least 20-25 millimeter. The key of successful implant this valve is to be matching the landing zone and the valve configuration, and it's feasible to implant this valve from the neck. A long dry seal sheet can ease up the procedure very nicely. And of course, the outcome, 6 years, the valve function still very intact. And explanting this valve is quite feasible and safe, even if the information is quite limited. So I will stop here. Thank you very much indeed.
Thank you, Worakan, for your excellent lecture and very interesting cases. Okay, let's move on to the last speaker, Dr. Choi from Yonsei University Hospital, Korea. He will talk about the melody valve, tips and complete cases in PPVI.
Okay, do you hear me now?
Okay, I can hear you very well. Thank you.
I'm very pleased to hear that because I had some issue on the audio. So thank you, Chairman, for the nice, kind introduction. My topic is the tips and complicated cases in PPVI for melody valve. The history of transcatheter valve replacement has started 2 decades ago, began by the first percutaneous pulmonary valve implantation of the Bonhoeffer valve by Philip Bonhoeffer. And during the first decade, balloon expandable valves were tested and approved, followed by the second decade of expanding the horizon by development of self-expanding valves and further expansion of applicability for balloon expandable valves, including melody valve. This slide shows a spectrum of congenital heart diseases that may be subject to the need for prosthetic valves in the pulmonary position. And a larger proportion of RVOT patients with a dilated native RVOT may not be a candidate for melody PPVI. So the use of melody valve has been restricted to a lesser proportion of patients, around 20% of RVOT patients. However, as the population of patients with bioprosthesis in the RVOT are increasing, and they may become a candidate for melody PPVI in the future, this proportion will continue to grow in the future. Melody valve is a bovine jugular vein valve inside the platinum iridium stent frame, available in 2 sizes, intended to dilate it up to 20 millimeter and 22 millimeter. The melody valve is delivered by a dedicated delivery system, the ensemble delivery system. This system has 3 sizes of beep balloons in 18, 20, and 22 millimeter outer diameter. With a designated rated burst pressure, the outside diameter of the valve may be dilated to about 2 millimeter larger than the balloon size. And as in other closed cell stents, the length of the valve foreshortens as the diameter increases. So if you're planning to dilate the valve more than 22 millimeter, 20 millimeter, or 22 millimeter melody valve is recommended. Initial patient selection criteria restricted the candidate lesions to a very nice preformed landing zone for melody valve. However, as the experience with the melody valve is accumulated, for the expanded use of melody valve has been proved to be safe and effective. And the current indications include a wider range of lesions in the RVOT. I would like to skip the detailed implantation procedures in concern of time. What about the outcome? Indebted to the lessons learned from the early series, including the Bonhoeffer cohort and the US cohort, the implantation techniques have been further modified. And now with the current techniques, the outcome of melody PPVI appears to be favorably comparable to the outcome of surgical PVR. However, still there are non-negligible risks of complications, making the procedure more challenging. Various measures to prevent serious complications have been suggested. And this slide shows various challenges in melody valve, the PPVI. I would like to cover 3 kinds of issues in this talk about coronary compression, conduit rupture, and how to safely relieve the fixed obstruction for a good landing zone for the effective melody PPVI. Incidence of coronary compression may be around 1% of the PPVI patients. Abnormal coronary artery anatomy known to be a strong risk factor. For the detection and prevention, pre-procedural CT angiography may be helpful to detect the risk of the coronary compression. However, coronary compression test is the gold standard, which should be performed with LT root angiography or coronary angiography during RVOT dilation with a non-compliant balloon matching the diameter and length of the intended implant. Once occurred, the only treatment may be the emergency surgery. The role of coronary stenting is limited as a temporary measure to gain the time to go to operating room. And there has been a report that the coronary perfusion restored by collapse of RVOT stent. There is a melody valve during the vigorous chest compression during the cardiopulmonary resuscitation. Coronary compression has been reported to occur also by shift of fractured calcium tissue or contained local hematoma after conduit rupture. So stepwise gradual dilation with recheck coronary angiography is required in patients at risk of coronary compression. You can see a coronary compression case in spite of a large distance between RVOT and coronary artery. And coronary compression may occur also in an unexpandable conduit with a metallic frame. You can see coronary compression by ballooning of a bioprosthetic valve with a metal frame. So I believe coronary compression test should be a routine test for most of the patients undergoing PPVI. The conduit rupture may be one of the serious problems in this setting, reported to require any intervention in about 6% of the patients, and a severe form with hemodynamic compromise in up to 2%, in which cases it should be the nightmare to the operator. There are several risk factors suggested in the literature, including heavy calcification, small conduit, high pressure dilation, larger the initial balloon size, and angled conduits, etc. Treatment of conduit rupture should aim at the safety of patient. Optimal treatment may differ according to the severity of rupture, including careful observation, covered stent implantation, and emergency surgery. This slide shows a self-limited confined rupture. At the time of this procedure, we didn't have a covered stent, so we implanted melody valve first, and then post-dilated using an ultra-high pressure balloon to relieve the residual stenosis. You can see a small confined tear with a very small communication from the proximal RVOT, and this small leak spontaneously resolved without any treatment. Then what to do with a more extended lesion, especially with concerns of ongoing expansion? Covered stents have been reported to be very helpful by bailing out of the conduit perforation. And this slide shows a long length of tear on the RVOT occurred during coronary compression test. They implanted a cover stent to bail out the rupture. They used a cover stent long enough to cover the whole length of a narrow segment. You can see that contained tear and rupture in various locations and types can be treated by bail-out use of a covered stent with subsequent successful transcatheter pulmonary valve implantation. However, in case the rupture is incompletely covered, the hematoma may progress to expand with time, necessitating subsequent surgery. Then how to prevent a conduit rupture? A prophylactic pre-stenting using a long covered stent with subsequent serial dilation may be helpful in patients with calcified and or small conduits with a high risk of rupture. This slide shows the implantation of a covered stent in a severely stenotic calcified homograft to prevent condylar rupture, followed by gradual overdilation and the subsequent successful melody valve implantation. However, there have been questions regarding the expansion of this strategy beyond the usual indication criteria of candidates, and a few reports have been recently published. I would like to briefly review the largest series among those studies. They studied 117 PPVI patients with implanted conduit the size less than 16 millimeter. Homograft and contactor could be overdilated about 30%, larger than the original size. Many of them had heavy calcifications. Pre-stenting was required in most of them, and many of them required multiple stents and confined and hemodynamically stable conduit tears occurred in about 16%. And fortunately, there was no catastrophic extensive condylar rupture in their study. Conduit tears were associated with the small and more shrinked conduit, especially when it is dilated with a larger balloon from the beginning in their study. Then how to overdilate RVOT conduit? After coronary compression test, start with a smaller balloon, dilate with stepwise and gradual increment of the balloon size. Implant a covered stent before the balloon diameter reaches to a risky size. The length of a covered stent should be long enough to cover the whole length of a narrowed segment. Repeat coronary compression test in case of any doubt. And once the landing zone is prepared, you can implant the valve. This slide shows a case with a pulmonary atresia with VSD, multiple MAPCARs, and very complex medical history. She underwent Rosselli operation 19 years ago with the RVOT conduits made from the Wessex pericardium, and only HEGA was passed, HEGA 40 millimeter over HEGA was passed, barely passed the conduit at the time. We gradually pre-dilated the conduit with low pressure, followed by implantation of a cover stent long enough to cover the risky area. After cover stent implantation, we dilated the conduit more aggressively using an ultra-high pressure balloon, which abolished the residual waste. Since a nice landing zone has been prepared, the melody valve implantation was straightforward with a good final outcome. On the other hand, with more experience of melody valve, it has been a consensus that the presence of a surgically inserted bioprosthetic valve may offer an ideal substrate for melody valve implantation. And there have been 4 studies on valve-in-valve melody implantation inside the deteriorated the bioprosthetic valve. The success rate reported to be high with low complication rate and acceptable follow-up outcomes. However, it has been reported that the valve durability may be shortened by a smaller diameter of the implanted biostatic valve. So the presence of a restrictive, non-expandable stented bioprosthetic valves may be a challenge for valve-in-valve PPVI using the melody valve. The challenge may be stenosis occurred with acute angulation of surgical valves in the RVOT. In this patient, the previous surgical bioprosthetic valve, you can see a significant angulation of bioprosthetic valve relative to the RVOT, the long axis of the RVOT. This angulated the valve, deteriorated the obstruction. So we implanted a long stent to correct this angulation and then implanted the melody valve with a good outcome. In this case, you can see more angulation than the first case. We tested the feasibility of angle correction by a balloon inflation inside the valve, and then implanted the long stent, followed by successful melody valve implantation. In 2014, a good news for patients with restrictive surgical bioprosthetic valve has been published. The German doctors reported that the cracking the frame of a surgical bioprosthetic valve is feasible using an ultra-high pressure balloon dilation. And the feasibility, efficacy, and safety confirmed by series of bench testing and the early clinical experience involving the transcatheter valve in the pulmonary position as well as in aortic position. The technique involves valve dilatation using an ultra-high pressure balloon at the 10 to 26 atm, frequently over the rated burst pressure of the balloon, using the 1 millimeter larger size balloon than the nominal diameter of the bioprosthetic valve, or I think a slightly smaller balloon may also work. However, there are some valves which cannot be fractured by ultra-high pressure ballooning, including Hancock 2, trifecta, and some of recent version valves. So it is important to know which valves was used in previous surgery and whether it can be fractured or not. For additional information, the nominal diameter of bioprosthetic valve refers to the outer diameter, and the true internal diameter is generally 2 millimeter and up to 5 millimeters smaller than the nominal diameter. You can download an application to your smartphone and make an instant reference. This slide shows a case of a prosthetic valve ring fracture using ultra-high pressure balloon. We pre-dilated a St. Jude EPIC valve 25 millimeter with a true internal diameter 23 millimeter, which was associated with thick and degenerated leaflets. We used a 24 millimeter Atlas balloon up to 18 atm. You can see the disappearance of the indentation, the balloon waist with a separating gap on the metal ring here. In case, in this case, the Carpentier Edward Magna 23 millimeter bioprosthesis was dilated using an Atlas Gold 24 by 40 millimeter balloon. Pressure went up to the 22 atm over the rated burst pressure of this balloon catheter. You can see the cracking of the cracking moment with the sudden popping over the waist with a separation gap on the valve frame here. A 22 millimeter Melody valve implanted subsequently. We didn't post-dilate this valve because the Melody valve was fully expanded already. This slide also shows a valve frame fracture of a 25 millimeter St. Jude EPIC valve with a true internal diameter of 23 millimeter using the 24 by 40 millimeter Atlas Gold balloon inflated up to the 15 atm. Melody valve could be implanted with its full diameter with a satisfactory final result. Prosthetic valve frame fracture can also be done after Melody valve implantation. In this case, we implanted Melody valve first, and the residual waste was resolved by the post-dilation using a 24 millimeter Atlas Gold balloon up to 14 atm. So in conclusion, ladies and gentlemen, evolution of transcatheter pulmonary valve replacement technology has opened a new horizon for treatment of congenital heart disease patients with RVOT dysfunction. The outcomes has been improved and the applicability has been expanded. Every operator should be familiar with the challenges and risks of the procedure for effective prevention and treatment of complications. Thank you very much for your kind attention.
Thank you, Dr. Choi, for your excellent and very informative lecture. Now we can have a discussion time for about these three valves. Please show us all the speakers and panelists. If you have a question, please raise your hand, then I will. Yeah. Who will be the first? Tin? You raise your hand?
Hi everybody. I have a question for Choi. Did he has any case for the endocarditis after melody valve implantation?
So we have implanted the more than 30 cases of melody valve. Among those, we experienced the one that the infective endocarditis. He mentioned that he had some toothache 2 weeks before he developed fever. So we thought it was related to infection through some dental problem. And we treated the patient with the valve function was not so much deteriorated. There was some mild stenosis with the very mild regurgitation. And we administered 6 weeks of antibiotics. And the patient finally got free from the symptoms, and we are closely following the patients.
Okay. So for the bacterial endocarditis, any other cases with from the other valve, venous valve or PULSTA valve? Do you have any experience about the bacterial endocarditis after implantation? Beom.
Oh, just to share. Sorry.
Okay. Worakan.
Yeah, so let me do first. So in our series from Bangkok and from from Bangkok, we don't have endocarditis, but there was a report from China. There was endocarditis. So again, I think for me, I think any kind of valve on the right side heart can get endocarditis. So it's very important to take care of the dental procedure. I mean, teeth, and also the hygiene of the patient properly, and also the aspirin and long-term antiplatelet is very important in my opinion.
Okay, thank you.
Yeah, for the PULSTA valve, can I? Yeah, for the PULSTA valve, the history is not so long compared with the venous valve and melody valve. Until now, among 119 patients, there is no report of endocarditis. In our center, we already implanted more than 30 patients. No endocarditis until now, but we should be very careful. And for the aspirin issue, nowadays we are giving 1 year aspirin after valve implantation because we think the tissue is not so much compared with melody valve. Tissue burden there, so we are giving just 1 year aspirin.
Okay, but as we know, the bacterial endocarditis is associated with the residual pressure gradient on the pulmonary valve. So usually melody valve is implanted for the stenotic lesion, but compared with the other valve usually for pulmonary regurgitation, there may be a difference. Dr. Choi, in your case...
Can I share the slide? Can I show you the slide? Mm-hmm. I'm sharing the slide. Can you see the slide?
Yep.
Yeah. This is a comparison between the incidence of
melody
free from infective endocarditis between melody valve and sapien valve. Actually, the melody valve follow-up period is longer, but there is no difference. So this is nobody knows whether this is a fact or a myth. So I think that we have to closely follow on the data, but even though there may be some people anecdotally report that there may be some trend of more incidence of infective endocarditis with melody valve. Actually, the data appears not the same as many people believe. So, but there may be some many factors, influence factors, because the melody valve has been implanted in the relatively developed countries, And also in our hospital, we routinely screen for any dental problem before any PPVI. So nobody knows what is the truth, but we still very careful about those complications on follow for every valve, especially melody valve.
What's your policy for the aspirin use? For lifelong or?
The melody valve?
Yeah.
Yeah, melody valve, the lifelong, the indefinite antiplatelet is the general policy, the general, generally the accepted.
Okay.
But I still, after PULSTA valve, I still use the aspirin in every patient. So if the Beom will show you the evidence, then I will stop in the future.
Yeah.
Yes.
It will need more time.
One of the questions, Bharat, yeah.
The only comment I wanted to make was, what you said earlier. I think comparing PULSTA with a RVOT, which is native, versus Melody, where it is a RVOT has a RVPA conduit, I think it would not be the same substrate.
Yes.
So I think comparison of a native RVOT versus a conduited RVOT would be like comparing apples with oranges.
Yes, I agree. There's different situation. The one question from the audience is about after PULSTA valve implantation, the PVC very frequently occurred, but it's transient. How about, I think that kind of complication may occur in venous P valve too, because it may touch the alveolar flow tract and the PVC. How about your experience, Worakan? PVC?
Yeah, so for the venous P valve, it's about 10% of the patient. Immediate after implantation, the patient may develop RVOT PVC, which is almost all the cases that I experienced completely disappear. Just one patient actually, we did in Indonesia. So that patient needs the anti-arrhythmia just for a few weeks, and then we can discontinue. So again, that is because of the touching of the framework to the RVOT, which is inevitable. But again, it could be managed. So again, what I learned from the venous P is if you have the substrate of the PVC before the procedure, this is the thing that you need to probably think whether if you can use the very short segment of the valve just to avoid touching the RVT. It may, I can say may, reduce the risk of the PVC after the procedure. But there is no data to support yet.
Okay, thank you.
Yeah, the same opinion with the Worakan.
Any question from the panelists?
The one comment also with the PULSTA valve, if the valve involves the contractile portion of RV myocardium, the PVC, transient PVC may occur. So it is the same situation. But the difference is that venous P valve is a little bit longer than generally in length comparing to the PULSTA valve. So there may be a more chance to touch the contractile RV myocardium.
One question from Yasukochi in Japan. He asked about the aging limitation for pulmonary valve percutaneous pulmonary valve implantation. Age is related.
Lower limit or upper limit? There is no upper limit, just lower limit.
Upper.
Upper limit.
Old age or low age.
I think the TAVR procedure usually done in very elderly patients. So I don't know which problem will be the obstacle for the PPVI in elderly patients. I think maybe there may be some restriction of due to the comorbidity such as some renal failure or something like that, we should restrict the use of a contrast medium in such a patient. But outside those comorbidity problem, I think PPVI is still feasible in elderly patients.
Yeah, in any age. Recently, I put two PULSTA valve on each pulmonary artery. He is 60 years old, no problem at all. So I think that the age is not a big issue in PPVI. Any questions?
Sangho, may I share about this?
Uh-huh.
Yeah, I think in the future, very soon, there will be so-called valve in valve, either in valve.
Yes.
Procedure for the pulmonary position. So I think as you said, and as all the panelists and also the experts say, that there's no exact limitation for adult. I mean, how old? I mean, the oldest one could be like 60, 70. I think should be okay. But again, I think the future will be like valve in valve. So we need to think about how to make it happen. I mean, second time or third time. So that's my view. But for the challenging view would be how young of the patient that we can put it in. I think this is quite interesting because, as I said, that the valve longevity is limited. We don't know exactly, but at least 8 to 10 years roughly. So it means that if you put the valve so early, you may need to put the valve again and again and again. And also the limitation of the delivery system that may reduce the feasibility of the valve implantation. So I'm not sure about Beom or Jay. What is the youngest patient that you treat? For me, the lowest body weight is about 28 something kilo. Again, I try not to put the valve so early. I try not to put the valve in a small child, but I don't know. What's your experience on this?
Okay, it's a very good point.
Actually, the limitation is the initial any study for the studies for the PPVI for any valve is the inclusion criteria, exclusion criteria was the less than 30 kilogram of body weight. So those initial experience has restricted the use of this valve to a younger patient. But the more important concern on that is that the bioprosthetic valve, the surgical bioprosthetic valve in young patients, surgeons found that the valve degeneration occurs earlier. So durability of the valve will be shorter than the valves implanted in the adult. So that is the only concern. But if once the delivery system, future technology may reduce the size of a delivery system, then we can put the valve in any age, in which the patient has has enough access to allow the sheath size. But it is for the reducing the time of surgery, but the durability may be much less than the valves implanted in adults. What do you think, Kiba?
Yes, for me, I just stick to the approved criteria for the PULSTA valve implantation. So more than 10-year-old and more than 30 kilogram. But when I stayed in the United States 7 years ago, I saw one patient, 5-year-old. They implanted blood valve there. So some patients need some specific treatment for alveolar digit, and if we can escape the surgery and the vessel size permit, I think we can proceed the PPVI, like Dr. Choi said.
Kibam, I have a question.
Yeah.
So for the self-expanding valves, they don't manufacture the smaller valves. the only way to do the PPVI in smaller patient with the small alveoli is the self-expander valve. The melody valve has proved to be effective in 12 to 14 millimeter conduit. So, but the problem is that durability still. The problem is the durability. So it works in a very small diameter, but maybe I don't believe that the manufacturers of the PULSTA and the venous P valve will produce smaller valves such as 12 millimeter or 15 millimeter. They will not. Yeah. But the only way is
difficult to make that smaller valve.
The market is not so large for the developing such a small valves.
May I share this a bit, Jay? This is very interesting. The point that you made, I think, there's a PICS meeting just last week. So what I saw from Dan Levy, he did research on the expandable platform for the coarctation in children. So I'm not sure whether in the future, if we can put 22 millimeter, for example, PULSTA valve in 10 millimeter, native alveoli, and that can expand in the future. I'm not sure, but just imagine. And another thing, Beom, I think the PULSTA valve has very sleek delivery system, which is quite similar to the melody valve. I think that's a room of future improvement to use this kind of system in small child. I'm not sure whether if we can develop, in the future, make it more comfortable to a small venous site, and that'd be great.
Yeah.
But for the PULSTA valve, the radial force is not so strong compared to the venous P valve.
Right.
So we should be cautious to put a PULSTA for a stenotic lesion, even though we dilate before with the high pressure balloon, but it recoils. So we need the pre-stenting for.
Of course.
Yeah.
So usually the radial force of PULSTA valve is stronger than the ASS sizing balloon and lesser than Taisha balloon. So between there in Taisha PULSTA valve radial force.
In terms of atmosphere, how do you have some exact number?
Yeah, so it depends on the valve diameter and valve length and valve the wire diameter. So we did multiple bench test, and usually the radial force generally less than 1 atm.
Okay.
So one thing is I'd like to emphasize is we can put a percutaneous valve in many patients, but they also can treat it by a surgery. So we should make a lifelong plan when the patients need a surgery or valve. Recently, one paper showed us surgical PVR is more risky than when the age is more than 37 years old. It reported from England. So when the patient's coming in 20 years old, we should consider surgical or percutaneous, even though we can put a percutaneous valve right now. So the lifelong strategy is very needed, but we don't know the still.
So the Worakan told that in the future valve in, but if the surgeons believe that too large bioprosthetic valve is not good for durability of surgically implanted bioprosthetic valve, Changa is there. Ask Changa what would be the best optimum size of a valve for surgical PVR. Please ask the Changa.
Thank you for your question. Actually, now we are trying to do put the prosthetic valve about 25, 27 millimeter because we expect next time PPVI procedure.
27 trifecta, the Hancock tool, right?
Yeah, right, yeah.
Yeah, internal diameter is less than 25 millimeter, 24 millimeter. Then if you put a valve inside the 27 millimeter valve, the inside diameter of a percutance valve will be less than 24.
Yeah.
And the next time, at least 2 millimeter decrease of the internal diameter. Then just twice or three times is maximum.
Yeah.
So I believe if surgeons put the valve, larger valve, then we can do more. More times about the PPVI, but if surgeons put the smaller valve, then the repeated time of PPVI will be restricted.
Right.
But one
Yeah, that's
thing
very
is,
fair,
I do
wonderful
believe
point.
biological valve may be invented in 20 years. So
Yes.
at that time, no problem at all. Okay.
Song Ho, may I share just one short thing?
Oh, okay.
About the, at least my experience, one case, as I show you, the venous P valve explanted. Before, previously, I was quite concerned, similar to the surgeon, that how can we explant this valve, which is so, big distally and proximally. But eventually, when the surgeon did try to explant it, it's not that a big deal for them. So that's quite encouraging me, at least as operator, to put it in, even if in not like 20 years of age, but 15 or even 10 years of age, because I think it's quite okay, at least for the surgeon to take it out.
I have a question to Worakan.
Yeah,
Some
please.
comment there. So when I attended the first the venous P valve workshop in your hospital, my biggest concern is about that. And I asked the Shaq about that, and Shaq answered the surgeon can do anyway. So that was my biggest concern. Looking at the animal test, after animal sacrificed, if you look at the valve inside the pulmonary position, then complete re-endothelialization was observed. So it is completely adhered to the native tissue. So I was very much worried about that, especially on the RV muscle proximal aspect. It may adhere to the RV muscle, but I'm very happy to see that today your case. So very comfortable. Thank you for your
too.
case.
Thank you.
Okay, but I think in the PPVI, imaging is most important thing. Which size device, what kind of valve, to decide that we should have a very nice imaging. I would like the three speakers. What kind of imaging modality do you believe best? Dr. Kim, first.
Yeah, for me, I'm using echo CT for the feasibility to do the first valve implantation, and the precise valve sizing selection to cine angiography and the balloon integration test. So
Same with Dr. Beom.
yeah.
So I personally, I don't believe echo measurement because echo has some blurred image on the margin, and the interventionalist on working on the LA appendage closure or TAVI, they don't believe echo measurement, and they usually oversize the echo diameter because of the blurring on the margin. So I am referring to the CT. CT in the both systolic and diastolic phase, and also the balloon interrogation test, and also make some imagination of a valve implanted on the RVOT in MPA angiography. So three kinds of size match, and if one size is not matched to the other two, I'm the measure once more with the repeated balloon interrogation test.
Yeah, confirmed by balloon. Yeah,
Yeah.
I believe the CT and the 3D reconstruction is very helpful for find out the best angle for find out landing zone. So previously I used the vessel navigator, but Now I use the CT 3D image and rotate it to find out the best image, and then finally confirmed by a balloon. Then I decided which device and what size device.
Song-ho,
Yeah,
you have a 3D rotational angiography.
yeah,
I envy you.
yeah.
We don't have.
We'll buy a new machine in this year. So
May I share with you about this a bit? In terms of imaging, I mean, non-invasively, either CT or MRI, I think depends on institution. But for the CT, the key is, I think you need, at the moment, if I understand correctly, you need ECG gated because systole and diastole will be, not similar in terms of the diameter. But for the MRI, I think it's quite good because you can see the pulsatility very nicely. So I personally prefer MRI as a screening. And with the MRI, I think you can use that for the 3D model, at least to show. For me, if there's a waist, especially if it's in the middle or in the proximal part, I think that's quite feasible for PPVI. What kind of valve should be okay. But if the waist is so distal near bifurcation, I think that's very cautious. That you need to be, keep in mind that may not be good for any kind of valves. And after that, as Beom and also Jay mentioned, that's very important to get a proper balloon interrogation, because the final destination, final decision will be rely on only the that balloon that fits to that anatomy properly.
Okay, thank you. Yeah, there are so many issues to discuss about the PPVI, but we have not enough time. Thank you for all the speakers and panelists. And I would like to close this session. And
Thank
next
you.
session by Dr. Chanali. Thank you.
Thank you.
감사합니다.
Bye bye.
Thank you. Thank you. Bye-bye.
감사합니다.
Bye bye. See you again.